Hello, my name is Dr. Brian Monahan, the attending physician of the United States Congress. I would like to speak with you today regarding an update to the novel 2019 coronavirus, SARS-CoV-2, as of March 2, 2020. I have no doubt you have been following this story closely and have seen my recent video summaries. The novel coronavirus is a virus like the Middle East respiratory viral syndrome and the SARS coronavirus. The natural reservoir is believed to be associated with bats. The precise animal reservoir for the current coronavirus infection has not been identified. The virus began circulating among people in November 2019 in the city of Wuhan, China. As the virus has not been in widespread circulation in humans before, there is little natural resistance to infection. Subsequent person-to-person spread has led to the dissemination throughout China and other nations with great social, cultural, and economic impacts in that nation and internationally. The initial attempts to control the spread of virus have focused on tools to limit the travel of people from areas where the virus is present and social distancing to limit the factors leading to person-to-person spread. Although a promising strategy in small outbreaks of infection like the SARS outbreak in 2002, extreme measures of containment have not been fully successful in the current coronavirus outbreak. Since the time we last spoke, there have been some new developments. Just to review, the name for the disease caused by the 2019 novel coronavirus is COVID, COVID-19, COVID-19. The name for the virus is the SARS, SARS-CoV-2, SARS-CoV-2. The coronavirus has now spread to more than 53 countries and territories, many of these cases with no known link to China. There is no reduction in new cases yet, and new countries continue to emerge. Mexico, Algeria, Nigeria have been added to the list and are now facing growing difficulties. The Centers for Disease Control has added new countries to which travel should be deferred, including China, Iran, South Korea, and Italy. We are now beginning to see cases in the United States occurring without a known link to China or exposure to other cases. In the state of Washington, there have been 2 deaths of a man in his 50s with a predisposing medical condition and an elderly resident of a long-term healthcare facility. Additional cases in a healthcare worker and an outbreak of several cases in a long-term care facility have also been reported. There are also deaths now reported in Thailand and in Australia. More worrisome in the United States now is a cluster of cases in the Life Care long-term care facility in King County, Washington, where there is potential to confirm many additional symptomatic cases among this very vulnerable healthcare setting. In regions where fatalities are reported, you should anticipate the announcement of many subsequent cases. So far, in the United States, there are greater than 90 cases. Approximately half of these represent the Diamond Princess cruise ship repatriation group or those who have traveled from China. Some recent United States cases occurred in Rhode Island involving a man in his 40s that recently returned from travel to northern Italy, and a woman in her 30s in New York who recently returned from travel to Iran. 2 adult cases in Florida were reported yesterday. There are no known cases occurring in the region of the District of Columbia, Maryland, or Virginia. Several individuals have been tested for SARS-CoV-2, but none were positive. The states where disease cases now reported include Washington, California, Oregon, Nevada, Texas, Wisconsin, Illinois, Nebraska, Massachusetts, Rhode Island, Florida, and New York. The CDC has suggested more cases are very likely to be identified in the coming days, including more cases in the United States. It is also likely that person-to-person spread will continue to occur. The CDC has stated that widespread transmission of the COVID-19 in the United States would translate into large numbers of people needing medical care at the same time. Schools, child care centers, workplaces, and other places for mass gatherings may experience more absenteeism or temporary closures. Public health and healthcare systems may become overloaded with elevated rates of hospitalizations and deaths. Other critical infrastructure, such as law enforcement, emergency medical services, and transportation, may also be affected. Healthcare providers and hospitals may be overwhelmed. At this time, there is no vaccine to protect against COVID-19 and no medications approved to treat it. Non-pharmaceutical interventions, such as social distancing, ill contact avoidance, surface decontamination, and hand washing, remain the most important response strategy today. This particular coronavirus threat has many distinctions compared to what we have seen before and is unlike the previous SARS outbreak in several important regards. There may be persistence of infectious viral particles on surfaces, and this can depend upon environmental variables such as temperature and humidity. Some reports have stated the viral particles may remain infectious for as long as 9 days on an environmental surface. This coronavirus has high levels of viral replication in the nose and the throat, facilitating its spread. For example, a woman attending church services in South Korea infected 231 fellow parishioners. Now there are at least 3,800 total infected in South Korean outbreak, with at least 18 deaths in South Korea. Infected people can transmit the infection in the absence of appearing to be ill. Methods of airport screening people with fever detection tools are not fully effective, as most cases initially did not have a fever at the time of diagnosis. Overall, this coronavirus is less deadly than SARS, but more contagious, with one person accounting for spread of virus to 2 or 3 other people. This accounts for the rapid growth in the number of people who are ill once cases of transmission are established. The SARS-CoV-2 has a wider spectrum of severity, from asymptomatic to minimally symptomatic to severe illness. The risk to the individual is not easy to predict. Traditional groups who have trouble with respiratory infections, such as the elderly, those with certain chronic illnesses, such as lung diseases, asthma, and immune suppression, do not fully account for the observation that some people without these risks develop severe disease. Among a large series of ill cases reported from China, men who may have a higher coincident risk of tobacco-associated lung disease in that country outnumber women. Healthcare workers have seen a particular hardship with transmission of this disease. There are increasing secondary effects of care for infected patients that have been seen in China and other countries, causing the severe limitation of healthcare availability for other patients who need care, such as those needing surgery, cancer chemotherapy, or dialysis. There have been many reports of stigmatization of entire groups of people based on their race or nationality, leading to hardships for the daily life for these people in those regions. Many of you are certainly familiar with the cruise ship experiences, such as the Diamond Princess and its 771 passengers that finally came to an end on March 1st with evacuation of the last crew member. For those of you who don't recall, on the 1st of February, an 80-year-old man left the ship and became ill with coronavirus. 7 days later, 16 people were ill. 16 days later, there were 454 people ill. And on day 16, the United States evacuated 328 asymptomatic people, of which 44 later proved to be virus positive. 30 days later, at the end of the evacuation, there were 702 ill passengers from the shipboard exposure. In discussing the coronavirus enumeration, we are still hampered by data limitations. The case definition has been variable, and in China it now includes those with CT scan findings from their chest x-rays in cases without PCR testing. Most countries lack the PCR test capabilities. This has led to a massive undercounting of infected people. There has also been lack of transparency issues due to issues of stigmatization and identified groups in different nations. In China alone, greater than 79,000 cases and greater than 2,800 deaths have occurred. The critical issue of testing patients for the SARS-CoV-2 virus to discover the prevalence of infection continues to evolve, with the Centers for Disease Control sending replacement testing kits to state health laboratories. The Food and Drug Administration has modified testing regulations to allow other laboratories with the required expertise to use test materials that they have locally developed and for those that have applied to meet the revised FDA standards. In the very near future, the CDC will ensure every state has access to locally available PCR testing resources. The Centers for Disease Control has also revised the patient under investigation definition to allow physicians to have more latitude in selecting those for testing. The reduced availability of testing has hampered the responses of many governments around the world. In many countries, initial testing efforts were plagued by large numbers of errors with performance of the test. We will not have a rapid, simple test for doctors' offices or clinics for the foreseeable future. Many people are concerned with the chance of death from acquiring coronavirus infection. In discussing the statistical risk, precise use of language is critical. The symptomatic patient mortality risk, known as the case-fatality ratio, is not precisely known, but may be approximately 1.6% based upon a series of patients reported from China last week. This is compared to a case-fatality rate of 0.1% for influenza and 2% for the 1918 Spanish flu pandemic, or more recently 23% with the previous experience of the MERS coronavirus in 2012. The mortality risk that includes all number of people carrying the infection with or without regard to symptoms may be much lower, perhaps 0.3 to 1%. Generally speaking, you could view this COVID-19 illness as much worse than influenza, but not nearly as bad as SARS. However, 1 to 2% mortality should be considered a very significant mortality rate. Additional information is becoming known from the natural study of those who become ill from acquiring the disease. This is called the natural history of the infection. The incubation period from exposure to the onset of symptoms is typically between 4 and 7 days, and in some cases may exceed 14 days. Approximately 80% of people infected are ill with a mild infection, and most did not have a fever at diagnosis. They then recover. At the end of the first week, among those who are ill, 1 in 7 develops pneumonia and some difficulty breathing and other symptoms. During the second week of the illness, the body's immune system response begins to compromise and destroy lung tissue and other organs in an attempt to clear away the viral infection. 6% of those with pneumonia have critical illness, including respiratory failure, septic shock, and multi-organ failure. Scientists around the world are studying possible treatments for the virus involving previously available antiviral drugs, some long known, others still investigational. In the future, a vaccine will be developed, but this will require time to manufacture, test, and distribute the vaccine and prove its safety and effectiveness. What can you do now in your workplace? You can promote avoidance of infection by avoiding close contact with people suffering from acute respiratory infections. Individuals who are ill should stay out of the workplace. You should focus on frequent hand washing throughout the day, especially after direct contact with ill people or their environment. People with symptoms of acute respiratory infection should practice cough etiquette, such as maintaining social distance, 6 feet, covering coughs and sneezes with disposable tissues or clothing, and hand washing. Within healthcare facilities, enhanced standard infection prevention and control practices in hospitals are especially important. Thank you for your attention.